Hi, I'm Joe Tucker. I'm an infectious disease physician and delighted to be with you here today to talk about digital and decentralized approaches to HIV STI services in the post-COVID era, promise and peril. And in sort of broad terms, testing and HIV and STI testing in particular has really moved from the clinic and from sort of centralized units into people's homes and into people's lives. I'm going to go through the main messages of the talk. Digital approaches can increase patient engagement in HIV STI testing services and make them more user-centered. Decentralized approaches, especially self-testing, will push HIV and syphilis testing into the community settings. And both digital and decentralized approaches have potential perils that require careful consideration. Before I start, I'd like to just reflect a moment on COVID. Arundhati Roy said, "The pandemic is a portal." And I think this is very true. To kind of go into a more extensive quote, Arundhati Roy said, "Historically, pandemics have forced humans to break with the past and imagine their world anew. This one is no different. It is a portal, a gateway between one world and the next. We can choose to walk through it, dragging the carcasses of our prejudice and hatred, our avarice, our data banks and dead ideas, our dead rivers and smoky skies behind us. Or we can walk through lightly, with light luggage, ready to imagine another world and ready to fight for it." So today I'm going to talk a little bit about how after this portal of COVID, what do I think the HIV and STI services are going to look like, and what are some of the changes that will stick? In terms of the talk, I'll first discuss a little bit of background and then talk about digital innovations in HIV and STI services, really focusing in on testing specifically, and then talk a little bit about decentralized innovations in HIV STI services. So first, COVID-19 policies have moved more people online. A lot more people, older folks, in remote areas and rural areas, are all spending more time online. COVID-19 responses have also made people familiar with self-testing. So on the right, you can see a self-test kit, and many people have used COVID self-test kits, home test kits, and this is really decentralized health services. Telemedicine and related digital infrastructure has expanded greatly during COVID-19. In low and middle income countries, this could be as simple as a phone hotline. In higher income countries, this could be video conferencing and teleconsultations, seeing patients through the internet. So first, in terms of digital, there are a number of participatory elements that provide a structured mechanism for stronger patient engagement. And here I'm thinking about crowdsourcing open calls, hackathons, sprint sessions. It used to be that we could develop a new service and patient engagement was sort of an afterthought. And I think COVID and even prior to COVID, there's been a great emphasis on patient engagement. And this is also an area where HIV patients and researchers have been at the very forefront of these battles since the 1980s. So if you look at how patients have been involved in changing drug approval processes, I think it's really there's much that the HIV world has sort of figured out, and other parts of medicine have followed behind. And there's data from systematic reviews and RCTs showing that these approaches are not just nice or help, but they're actually effective and evidence-based. And to give you an example, a more granular example, I'll talk a little bit about crowdsourcing. So crowdsourcing has a group attempt to solve a problem, and then shares or implements solutions with the public. And why is crowdsourcing important to improve health? There are a number of existing digital networks that create rich opportunities for improving services. And there are insights from many fields about group genius. And then finally, big data is available. So crowdsourcing and crowdsourced approaches have really stepped up during the pandemic. Crowdsourcing open call, when I say an open call, this is what I mean, that it's first organizing a community steering group to get strong buy-in from the very beginning, to resonate with local culture and preferences, and then engaging the community to contribute. This clarifies the open call for community members and provides feedback on submissions, and then evaluating contributions, either through a crowd judging or a steering committee judging process, and then recognizing finalists through a prize-based system. And then those sort of exceptional finalists could be either implemented or shared through an open access resource. And these steps are outlined in a crowdsourcing in health and health research practical guide that our team developed in partnership with TDR and the CHI network. So what I mentioned before, there are many lines of evidence supporting crowdsourcing contests in HIV and STIs. You can see from this table how different crowdsourcing open calls have been used to develop new services to increase HIV testing, to promote condom use, to enhance engagement, and to promote sort of STD testing. You can see there's a wide range of different purposes here in terms of crowd contribution and what can patients and others contribute. They can contribute videos, images, concepts, slogans. There's really a number of different ways that the public can be engaged. And thinking about digital HIV, STI testing interventions, if you think about the testing continuum, promoting testing, focusing testing, services, ordering and receiving self-testing kits and results notification, there's a number of ways that digital technologies can enhance these different steps along the continuum. So websites, email, mobile apps are used increasingly. Text message interventions have been evaluated and sort of across this spectrum of services. And then there are also new technologies, wearables, remote monitoring sensors, AI, that have been used to generate demand and sort of promote testing services. And this speaks to one of the big kind of differences, I think, between conventional testing, which you see here on the left, versus decentralized testing on the right. So if you think about conventional testing, it tends to be more top-down, medically driven. The payer is health insurance or government. It's more confined to clinics with labs, and the function is to diagnose disease, so more narrow remit. The scale is often limited, and it's an opt-in or sort of more exclusive approach, versus decentralized testing is often more bottom-up. It's more people-powered. The payer can sometimes be the patient themselves or other individuals. The locations are more variable in primary care settings, in schools, churches, and the test function isn't to give a definitive diagnosis, but rather to spur someone to get into a clinic and receive the initial test. And the scale of decentralized testing is really larger. It could involve mass testing and be more inclusive and sort of use opt-out approaches. So this is just one example of self-testing from China. Our team organized an RCT among 451 gay and bisexual men. They were recruited from cities all over China, and the testing outcomes were ascertained by photo verification on a smartphone. 63% of MSM who were assigned to a self-testing arm ended up receiving HIV and syphilis self-testing. only 15% of those in a standard of care sort of facility testing arm received HIV and syphilis testing. So this shows how there are real opportunities for self-testing to expand the scope of diagnostics in some areas. And if anything, COVID here may have increased demand for self-testing services. The RCT here did some adjustments and sensitivity analyses to look at this point, and it didn't really affect the main findings of the RCT. This is a preprint from Wang Cheng, and I think this line of looking at self-testing, self-collection, and sort of decentralized services is going to be important moving forward. In terms of decentralized testing, there's a whole typology here, a whole bunch of different places where testing could happen. So in primary care settings, this would be at clinics that don't have laboratory services, and these kind of smaller clinics could still provide self-tests or self-collection. Institutional settings are also important. This could be schools, pharmacies, churches, and it would provide some infrastructure and institutional support for getting people into care. And then self-sampling, which is when you collect the specimen yourself and then send that specimen to a lab. And this could draw on dried blood sampling or a self-swab collection. And the disadvantage here is that it's less strongly tied to clinical services. And then finally, self-testing, where you take the test result yourself and interpret it, and there's no need for a centralized laboratory. There are already HIV and syphilis dual self-test kits available, but there are some disadvantages of this approach as well. But there are also perils associated with these new kinds of approaches. In terms of equity, will self-testing only be available to those who can afford these test kits? Coercion, will marginalized groups be further disempowered and forced to use services? Although I should add here that several systematic reviews have looked at adverse outcomes associated with self-testing and found that they don't increase the risk of coercion. Linkage to care is also a really critical piece here. Will those who test negative seek clinical services afterwards? And then sustainability as well. Will programs that started on free testing models be able to sustain themselves over time? And finally, from a research perspective, measurement. How do we know that an individual has used a self-test other than self-report alone? So going back to our main messages, digital approaches can really increase patient engagement in HIV and STI testing services and make them more user-centered. Decentralized approaches, especially self-testing, will push HIV and syphilis self-testing into more community settings and sort of create new pathways and new ways of getting folks into care. And both digital and decentralized approaches have potential perils that require careful consideration. So now I'd like to wrap this up, and a note of thanks to our SESH team. SESH stands for Social Entrepreneurship to Spur Health, and our research is supported by the NIH, and the systematic review that focused on decentralized testing was supported by FIND. So we're really excited to share these results with you today. And I'm sorry I won't be able to make the discussion presentation, but my colleague, Dr. Wei-Ming Tang, has graciously agreed to join you. So feel free to email me if you have any questions, and I hope the rest of your conference is great.